Henry, followed by a flag salute.
Our Father in heaven, as we gather here today, we praise your name and exalt your holiness. Lord, we know that you created the heavens and the earth, and that you are still totally and firmly in charge of it. And Lord, help us to be good stewards of what you have created. Today I raise up our commissioners, Lord. Guide them, give them wisdom to make prudent decisions in the matters at hand. Lord, I offer this prayer in the name of your Son and our Savior, Jesus Christ. Amen.
I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Okay, health insurance discussion. So start out with an overview of the process to date. Sally, would like to have a chair with us.
Good afternoon. I have information in these packets that we'll touch on, and then we'll have Bruce take over from there at this side. So the information on the right side is what we'll talk about in the next few minutes. And as you can see, there's information with Blue Cross along with Delta. Blue Cross having that very nice benefit that we're used to. Still makes sense financially when you do comparison next to Delta Dental. There's one common theme among the carriers that are presented in the US, and that is no two plans are exactly the same. So there's always differences, whether it's in deductible, co-pays, co-insurance, maximums, networks, things of that nature. So there's always a little bit of difference there when doing that comparison. But overall, you'll see the summary for that is towards the bottom. Financially, I would say it doesn't make sense to move because of the nice benefit that we have, and it's not enough of a savings to make that switch there. Behind that page, you'll also see disclaimers that we put in, for any of our production and any publication that we set out. And then finally in the back there's listing of information that we took to market based on the size that we are and who was interested in a group of our size and what we could bring to market and what we had available. You'll see that some were received but were not competitive, and then some say DTQ on that, and that basically means decline to quote. And under the Affordable Care Act, all are obligated to quote. However, in that situation, many times because they don't want to take on the risk, they will provide a rate that is so high it doesn't make sense to ever consider that. And so down below that, you'll also see the Delta Dental that we looked at as well. And we only look at A-rated carriers by AM Best rating or better when doing those marketing reviews. On the right side, you'll also see that there's information on United Healthcare from a fully insured standpoint. So we'll look at something that's self-insured in just a minute to show you that it's not competitive and to show you how the costs are lined out. And so you'll see that information on the United Healthcare is provided in this first fold-out page. You'll see that the first page is here, and then the second on the benefits are identical on the back. The difference is that one offers a 2-tier plan and then the other has 4-tier. In other words, if someone were to just want coverage for their employee and their spouse only, then they could do that without paying the full family amount. Typically, when carriers rate moving from 2-tier to 4-tier, it evens out financially. So carriers are paying about the same because they're not sure who will change. They're not sure whose spouse may find coverage at their own employer or perhaps take their children over there as well. And so for the first year, that premium is usually fairly the same 2-tier to 4-tier, but quite a bit different, as you can also see when you're looking at the single coverage compared to the 2-tier versus the 4-tier. You'll also see under the United Healthcare that the plans are not the same. Of course, we had mentioned that before. There's different deductibles and co-insurance. So again, just a recap on how that works is that deductible that accumulates throughout the year that starts April 1st accumulates, and then once that's met, then it goes into that next layer of coverage called co-insurance. So co meaning the employee pays a portion and the carrier pays the other portion to a maximum, and the maximum Blue Cross has of the co-insurance is $2,500, and that option 1 on United is also $2,500. And then the other two apply towards that maximum out of pocket. So the exposure, the maximum exposure for the option 1 is $3,000, and that's it for the entire year, and that includes all co-pays, deductible and co-insurance. And then the other two plans, the maximum is higher, as you can see at $6,500. Make sure I stay on track here. You'll see though, down towards the bottom, that overall it doesn't make sense this year to consider United Healthcare financially. The premiums are overall more expensive, and to make that change not only with the benefits but also with the higher premium, it doesn't make sense to consider United, but wanted you to see what the difference was there. So what I'm going to do next is have you look at this page here. This looks like a whole lot of information on one page, and it is. But this describes how the costs for self-insured plans are broken out. So we're very used to seeing one premium, we pay the premium, and then the insurance carrier pays for any claims that we have. Well, this breaks it up a little bit more in several different ways. First, there's a way that breaks it up between the expected costs that we might have for the claims, and then the other part to that is the administrative costs of the network of processing the claims. And so those put together are typically what you pay today for your premiums. And here, if there's any savings, perhaps if claims are not as high as we expect, or we're running good and we're seeing how we're able to better use the claim dollars, then that's where we begin to see that savings there. We don't pay any profit, if you will. And so for that first section up there, it just breaks it down into the different costs. So the specific stop loss, that's for the individual. Behind the scenes, we're kind of acting now as the insurance carrier. So the specific stop loss would pay maybe $40,000 or $50,000, depending on which option we're looking at in a worst case scenario. The aggregate stop loss is everything together on a claims basis in a worst case scenario there. And so that is added together for our total fixed costs. I'm going through this fairly quickly because as you'll see down towards the bottom, it doesn't look like self-insurance for us is a competitive option. But we did talk about this earlier this year, and I think it is a goal long-term to get there. And so as we're considering this, you'll be able to see and learn through the process as we're getting through that. Okay, and then we also have the other fixed costs in there, and that describes things like processing claims, the network, anything of that nature. Then we also have the total fixed costs, which are the stop loss premiums for paying those claims. So you don't have that full exposure if many things terrible happen. And then we have the expected claims factor. This is what we expect to happen. It could be better, it could be worse. And so with the expected claims factor, this is also brought in here. And then that maximum claims factor, again, the worst case scenario here. Those are the maximum claims we would be expected to have to pay out. So I think the bottom two sections best outline the gap between what we could expect to pay from a self-insured standpoint. We have the fixed costs, which we have to pay regardless, those processing of claims and the exposure risk, in addition to the expected claims. And then we have the fixed cost, the same thing that we had before, but the maximum claims. So you'll see when we get our overall premium adjustment proposed to us, these premiums don't make sense at this year to move to. Any questions so far? Okay, a couple of other quick things I wanted to touch on before we turn the floor over to Bruce, and that starts with this. And I'll also refer to this, but I won't go through this. You can look through this at your leisure. The benefits strategy benchmarking report we have as the largest offered in the U.S. And we exceed 2,400 participants that bring information into us. And we specifically have information on municipalities as well as in our size and in our geographic location. So for that first page that starts out for Marion County here, we've got your information towards the bottom. We offer 3 different deductibles. We can also see that for the different cross sections there, so we've got groups 100 to 500, or in our geographical area, we've got not-for-profit and all employers all together. So we've got different medians rather of the deductible. So we have $1,000, but we can see that more out there have a median that's higher for that. Our deductible on the family amount is on the low side as well. So that's on the deductible. And then just moving on the next page, you'll also see our out-of-pocket maximum. So this is a little bit different in regards to we have a $5,000 maximum out of pocket, but others have a little bit lower. So there's that balance there, what makes sense to us, what's offered in our area. So when we're making decisions for this upcoming plan year, this gives us some reference points on, is it okay to offer a higher deductible? What are others doing out there? If I have a higher deductible, what about my maximum out of pocket? Maybe I should lower that to be more like others in our industry that we have. The next page, we have office visit co-pays. So for our primary care physician, co-pay is a little bit on the high side. Our specialist is a little bit on the low side. And again, it's finding that happy medium, what makes sense for us here in Marion County. And then we've got a couple of other pages on there, one being number of plans offered. So we have 3 plans offered here. It's not unusual to have more than that, but more often than not, there's just 2 plans offered. There's arguments all around. Some would say that just offering one plan, you've got the healthy folks bringing in a higher premium to help offset those higher claim costs. But then again, to make the employees happy, maybe they don't need all that coverage and they want to pay a little lower premium and have a higher out-of-pocket expense because they're probably not going to use it. And then we've got a couple of other pages there. One of them is on health savings accounts. So who offers health savings accounts? And of course we have to have a qualified plan, so says the IRS, to exist with a health savings account. And so there's nearly half of plans out there offer these health savings accounts, and more than half of those contribute towards the health savings accounts. And it doesn't have to be a great deal, but sometimes when there's an employer that's also matching dollars up to a certain amount, it might be financially beneficial to help have folks be more aware of what they're using towards the plan. And then finally there we have the employee contributions. So that's always a fun discussion when we're finding out, okay, what is our new budget? Where do we need to be to make everyone happy? Maybe long-term, what do we need to do to get there? We have some tools that we'll talk about towards the end on how to help with that as well. So with that, I'm going to turn everything over to Bruce from Blue Cross.
Thank you, Sally. Anybody else? Does anybody else need that? There you go. Good. Okay. Sally, thank you very much, and thank you very much for the county for the invitation. My name is Bruce Schultz, and I work for Blue Cross Blue Shield. I work out of our Hutchinson office, and I'm going on my 34th year of working for this organization, and I just want to say thanks to giving us this opportunity. I want to compliment Sally. I think some of the observations that she made are right on target, and I would tell you it appears that you're doing some things very right by market standards and what she was saying, so I think that's a good thing. This afternoon, though, I would like to talk to you about just several concepts and kind of give you a high-level summary. I would concur with what she's saying. Our self-funded proposal as well doesn't look very competitive as well, and so I don't know if that was factored into your analysis, but if you looked at Blue Cross as well, but I would concur that our self-funding would not be a recommended thing I would suggest for Marion County. In the folder that you have, there's a lot of information, so I intend to kind of give this kind of a high-level summation to where it might be a little bit more understandable, if you would, and I would guess I get maybe 15, 20 minutes or so, whatever.
Did you get the schedule? I thought I sent it to you, I'm sorry.
I think maybe you did, so yes, perfect. So, excellent. So, in that folder, if you flip behind the first cover page, it talks about Marion County, and then there should be like what I could describe as our discussion topics. And I want to focus on kind of some of the few what I think are key points for the county to consider. So the first thing is that this renewal date is 5/1. Your anniversary date's when your program rates change and subject to contractual changes as of 5/1. The bottom line is that we were projecting your increase to come in somewhere around 9%, but I was able to secure a 2.5% rate reduction in a concession organization made for the county. It'll end up netting out about a 6.2% increase over what you were paying last year. So in a time when we had a fairly difficult year, and you'll kind of see you guys are a fully insured account. None of the information that I can release to you is anything more than aggregate data. There's no specific information, because when you're fully insured, we're not allowed to release any sort of identifiable information. What I would tell you, though, as kind of a summary, if you'll note, is if you look at those projected loss ratios, we ended up having again, for about the fourth year in a row, claims levels that were higher than what we've ever had, and so we're in a pretty tough cycle. And when Sally talks about companies not interested in bidding, we've had a pretty tough run for 4 or 5 years now, and it appears that the claims have continued to escalate. If you'll notice on item number 2, the claims are higher than what they've ever been in the history that we've been taking care of Marion County. But I'm not going to be critical of that, because those things happen to all of us, and things can change very rapidly in healthcare, and 2 or 3 really tough claims years can be followed by a phenomenal year. And so I would think that maybe we're due, or at least I kind of keep my fingers crossed for Marion County is what I'm hoping for. But I did want to point out that what those projected loss ratios were on the health plan, your dental plan, and we've again had a pretty significant claims year for Marion County. As you move down that page a little bit further, it talks about some of the credibility factors. You've probably heard me talk to you about this historically, in that when we rate a group, we don't rate the group 100% on your own experience. We use credibility factors. We believe very strongly that a group of 100 is not that predictable. So we know that the larger the group is, the more predictable you are, the smaller you are, the less predictable you are. But we factor your group's experience to a degree of about 40%. So we actually do look at your experience to come up with rating. We know that in a group of this size that claims can fluctuate wildly from year to year. And if we were rating you 100% on your own experience, you may see huge swings in pricing, and that's not been Blue Cross's rating methodology. But it is a component of how we do rate your plan, and I do think it's important that we point that out. This past year we had 10 significantly large claimants, and you kind of see some of those numbers that I talk about, just as kind of an FYI for you to evaluate. I would also tell you at the same time that in addition to healthcare costs increasing, those costs are increasing across the country, and healthcare costs are at the forefront of everyone's mind. And at the bottom, I talk to you about what Blue Cross's trend analysis is. It kind of shows you that we're estimating that hospital costs are going up, doctors' costs are going up, prescription drug costs are projected to go up 7% annually. And simply put, it's a pretty tumultuous time in healthcare, as we all know. And healthcare costs, it's expensive to deliver healthcare, as we all know in this room. So, but it just does kind of summarize that. If you move to tab 2 in that folder, one of the things that I wanted to illustrate, there should be a rate comparison page that if you flip to the second tab, there should be a summary. And what I wanted to get to for the county, very excellent, Kent. It does show at the top, it tells us the enrollment that we have. And one of the things that we've done here for the county that I've always been a real strong component of is offering a consumer-driven plan, and the county does offer a triple option. Sally had talked about that in their analytics they look at that a lot of companies are offering 2 plans. We offer 3 plans. I like consumer-driven plans like this, and I think it's a great thing for the employees. You offer 3 plans ranging from your option 1, which is a $500 deductible, option 2 is a $1,000 deductible, and your third option is a $1,500. The differences between those 2 or those 3 plans simply is in the deductible only, because everything about the policies other than the deductibles are the same. So they have the same office visit copay, they all have the same prescription drug card, and you can kind of see by those numbers up at the top that in your current option 1, that lowest deductible plan, you've got 30 singles and 5 families. You have 37 singles in the $1,000 deductible and 7 families. And on the highest deductible, you have 17 people and 17 employee contracts and 1 family contract. So we have a real good, if you will, split and enrollment in the different plans. And we give people that option. We give your employees the ability to pick and choose which plan they feel best meets the needs for their families. And I think there's some value in that, what the county has done. It does show you what those monthly costs are and what those costs are on an annual basis. And then directly below it would show you what those renewal numbers are on an annualized and a monthly basis. And I want you to kind of focus on that right column where it says, it shows the 2.5 competitive concession. It nets out at the bottom. We'd be talking about a 6.27% increase over what your current rates are based on the current enrollment. I would also note that on that option there at the bottom, one of the things that Sally had also mentioned that kind of piqued my interest is that it appears in their analytics again that about half the employer groups they surveyed have high deductible health plans. I have proposed that you could roll out an option 4, which would be a federally qualified high deductible plan with a $3,000 deductible. If you'll notice that rate is approximately $250. It's well, precisely $240 lower than your current option 1. And I would think that would be a great offering for the employees here to offer a plan like that. Understand when you move to a federally qualified plan, the concept behind a federally qualified HDHP is that the plan pays you have no first dollar benefits. So you cannot have a prescription drug card, you cannot have an office visit copay. All expenses are applied to that $3,000 deductible before the insurance company pays anything. And I will tell you historically that in the groups that I've sold these concepts to over the years, that we'll get some people that might be interested. I quite frankly like high deductible plans. I think people become better consumers. But I will tell you that people will be very, very hesitant to move into that world because we're all a little bit spoiled by having plans that have an office visit copay and a drug card. The concept of it is that persons could save pretty significant dollars, and the idea behind it is you could take that savings and you would put that money in a health savings account. And the beauty about it is that money that goes into an HSA, the concept is that if you don't use that money and spend it on healthcare expensive items, that money can roll and build over time. So I think about employees that work here at Marion County, and I truly believe that if we rolled that out as option 4 and employees go into that plan, I would highly encourage them to set money aside into an HSA and try to build that money over time, and could be an incredible tool in their long-term plan as to would help them in their retirement planning, and I think there's huge value in that. Will everybody at Marion County move into that plan? Very doubtful. Do I think you might get a handful of people that might show interest? I think so. It's been my history with other counties, and that would give a little bit of buy-in. But I think it's just another option that you could offer to your employees that would show a pretty significant savings. The problem with it is that I don't want to oversell it, because I don't want people to base their buying decision simply based on premium alone. Does that make sense? So I do want to point that out. That is an option. Now you can either add it to your plan as option 4 or not. But based on what was the analytics would tell me that may not be such a bad approach to roll it out. And I will tell you, we'll put a little bit of a load on Tina and this young lady here, because when you move to a federally qualified plan, you have to, those individuals that choose that plan will have to move to a limited purpose flex account or an FSA, which gets a little bit complicated, but we'll work through those details. And you cannot put money into a flexible, under a Section 125, at the same time tax shelter money under a health savings account, if that makes sense to you. That may be more than what you want to know, but there are some technicalities with it that you really have to be aware of. I think about young people and even old people like me. I think there's huge value in moving to high deductible plans for people. I think there's huge value in it, and I will tell you, people do become much better consumers. And the idea that I like about it so much is that the risk is limited to $3,000. So if I end up having to need quadruple bypass surgery after May 1, the bill's $285,000, my liability ends at $3,000. And today, your option 1 is an out-of-pocket of $3,000 because you have a $500 deductible and $2,500 in co-insurance. Your option 1 has an out-of-pocket of $3,000. So it's right in line with the plan designs that you have today, but it works conceptually different than that. Does that make sense? Questions on that?
There's no drug card with that.
There is technically, under a federally qualified plan, you can't have first dollar expenses, so you wouldn't be able to use a drug card. So if an employee went to get a prescription and they go to a local pharmacy and they go to get their med filled and it's $837, they pay $837, and that $837 is applied to their deductible. But once they hit $3,000, then what would happen is we would then input a copay on their drug card that would be like what everybody else has. You'd still pay a $15.50 or $75. So if they had a $2,000 prescription after they met that $3,000, they would have a copay to meet for like they would if they were under one of the traditional plans. Yeah.
Until they got to 6,350, which is the maximum out of pocket. Is that right?
That's exactly right. So in that world, you have to understand that when you are in what the government describes as a non-grandfathered plan, you have to think about deductibles and co-insurance and co-pays, but all plans under federal law must have under them what's known as a maximum out of pocket. Now, it's just another layer of protection for your employees. You'd have to have a lot of claims to get there.
To get there. Yeah.
But it is another layer, it's required by federal law. All plans would have what I refer to as a maximum out of pocket or a MOOP. So very, very, very good point. So I did want to point that out on that page number 1. Directly behind it, one of the alternatives that I wanted to mention to you that may make some sense for the county to look at would be to transition. This plan would be, again, a non-grandfathered plan. It would be with the concept of keeping your medical plan looking the same with the same deductibles, the same co-insurances, the same co-pays. What this proposal would be to transition you to what I kind of describe as a performance-driven formulary. And the concept of it is that under your current plan, you have a prescription drug card to where you pay a 50, 75 copays depending on the prescription.
Or I think it's 15, 30, 45 right now.
Is that what it is?
Yeah, I think so.
Okay, 15, 30, 40, okay, 15, 30, 45. And if you transition to this, I would be proposing that we would bump those copays up to 15, 50, 75, and then add a higher tier for specialty case medications. I will tell you, any of the competition that's talking to you today will have a plan almost identical to that. They're all moving everybody to 5-tier drug plans. Effective January 1, the Blue Cross guy, you know what drug plan that I have? That plan right there. We moved all of our Blue Cross employees to that plan starting January of 2019. Will we get some noise from the employees? Very definitely, because it would pass some risk on back to them. The important thing that I would note to you is that based on some of the reporting that we looked at, no employee currently is taking one of the specialty medications. So their specialty meds, we don't see anybody that currently is taking a drug that would jump into that 150 or even up to that 250 copay category. That could change in 20 seconds. I mean, someone could have went to the doctor today and end up with a specialty med, and I would be very fearful about moving this. But if we did move you to this plan, we would reach out. We use a company that's called Prime Therapeutics. They're our pharmacy benefit manager. We would reach out to all your employees that would be affected, and we would give them a written notification saying that the med that you're on will need to be changed, and we would be very proactive in educating your staff on just exactly how that might work. The bottom line to it is, you'll notice down at the bottom, is that does generate a little bit of cost savings for the county. It doesn't keep the cost exactly level for you. I mean, my goal was to try to get you at a level increase for 2019. We'd be talking about a 4.1% overall increase if you implemented the additional, that moved to the Results RX prescription plan. It's a little more restrictive. It limits you to 30-day supply versus 34 days. You no longer have a maintenance list. It's more restrictive, and I will tell you, we're passing costs back to your employees. But I can tell you, we as a company made that decision. It's really what we're marketing across Kansas right now, and there may be there's a little bit of appetite for trying to control the prescription costs of virtually every employer in America right now. So that'd be a thought for you to get to as an alternative. I would say that may not be a bad approach for the county. Okay.
Are you limited by what pharmacies you can use?
You know, it'd really be the same network of pharmacies that we use today, Kent. So it's the same Blue Cross network that you would have presently. Mm-hmm. So, and I would also then say that in that packet of information in tab section 3 is the utilization information that just substantiates what I've given to you earlier. It kind of shows you how in essence we do rate, our rating methodology that we use. It also shows you the high cost claimants, and we actually identify dollars. We don't identify individuals. That's also in that section. In tab 4, Tab 4 is a summary of your dental program. The positive thing about the dental plan moving forward for this next year is that we are removing the 240-day waiting period on restorative services. That's no longer will be part of your dental plan starting in 2019. So, Tina, when you hire new people,
That's awesome.
it's a wonderful change and a needed change. In the past, if I was a new employee and I come to work here, you would have coverage immediately for the preventative services. But if you needed a crown, a bridge, or an inlay, there was always a 240 wait. We made a decision corporately to remove those 240 waits off all of our contracts. So any new hires that would come in, clean contract. So that's a positive change for the county. And tab 5 is kind of some of the summary pieces of all the plans. It's really what I describe as our plan features. Section 6, you guys do have our electronic enrollment system called Blues Enroll, to where you electronically add people, delete people from your plan. And then I want to kind of direct you to pay in tab 7, if you will, in that renewal, because there are some contractual things that you need to be aware of. And one of the good things that I think is being changed is that the second bullet point down indicates that we will now start covering 3D mammograms. And so I don't know if you go to the Hutchinson Clinic, but my phone used to ring almost nonstop because Hutch Clinic was doing 3D mammograms. We only covered 2D mammograms, and I would guess that's happening in Newton and Hutch. And so this is a favorable thing for your employees. We're actually expanding to where our contracts will now cover 3D mammograms, which I think is a good thing. And then the other note that I will make to you as well is that it notes that the contractual changes for 19 insulin pump and pump supplies will now be covered under the medical benefit rather than under the drug card. So that's a contractual change that we would make that I would explain to your staff in our meetings. And so a lot of information. I could probably really bore you with a lot of other details. I wanted to tell you that there are a lot of options, and these ladies have done a lot of work kind of trying to evaluate things. I was very pleased with our organization's willingness to work with me and at least provide some relief. The formula generated a significantly higher renewal than what I've ended up with, and so that's a compliment to you, and our organization does value that relationship. We continue to be a Kansas-based company. We continue to have employees in Kansas. We have our service centers and call centers in Salina and Topeka. And I'm quite proud of the fact that we're a Kansas-based company, and we are Kansans serving Kansans. And I think there's a lot of value in that for companies. And I, quite frankly, pride ourselves in taking care of our client base. And we think that's a critical component to healthcare. So, questions that you might have? Anything?
Back to that one that you said, the plan 4, where if you was to take it and you build up your health
Savings account?
savings account,
Yes.
it's still the same. If you quit, you lose it.
You don't. The beauty about being on a federally qualified high deductible is that it's coupled with an HSA, and we would have to find a vendor. I mean, Sally could help us find a company that we would use for the employees to put money into the HSA. The beauty about it is that the money that goes into the HSA is your money, is the employee's money. Once you terminate, that money retains, and you keep that money. It's yours. But the money must be used for qualified medical expenses. So if I get $10,000 in my account and the rear tire on my Harley goes out, and I need to spend $1,500 on my tire, and I pulled money out of that HSA, you could probably do that, but you better hope the federal government doesn't do an audit, because it must be used for qualified medical expenses. But what I like about it is it can help people in their financial planning long term. I personally believe, Randy, that if I would have started a federally qualified high deductible when I started with Blue Cross 33 years ago, that I'd have between $80,000 and $100,000 in my HSA today, that I could be using when I decide to retire here in the next 3 or 4 years. And you could use that money in that HSA to pay for qualified medical expenses. Would that be a tough transition? Yes, very definitely. I always tell the story that if I moved to a high deductible, I'd have to go home and sit down with my wife, and my wife would say, "Bruce, have you lost your mind? I love having an office visit copay, and I love having a prescription drug card. why in the world would we move to a plan that doesn't pay anything until we spend $3,000 out of our pocket? And my comment to my wife would be is that it's saving us $250 a month, and we're putting that money in a health savings account, and if we are blessed to be healthy this next year, all of a sudden our HSA has $3,000 in it. And what'd be wrong with that? And if we don't use it, it builds, and over a 10-year time period, all of a sudden we have $30,000 sitting in our health savings account. And that's the value of a high deductible health plan. And I really mean that. And most employers of any size would offer that as an alternative. Yeah, I like the concept, and it's very much supported with what she's saying. So, so any other questions on that? Anything? If there is something that's proposed or presented that looks different, I mean, and Sally made a very good observation earlier, it's almost impossible to compare policies. And so I simply would tell you, make sure that you look at deductibles, make sure you look at co-insurances and co-insurance amounts and what those maximum amount of pockets are. And because I can quote you a $5,000 high deductible plan that would save you even more money, but do we really think anybody would enroll in that plan? I don't want that for my family. But I mean, if you want it, I can probably get it for you. But yeah, so what my point is that there's tons of options and angles, and I like the concept of having a consumer-driven plan. You would have 3 traditional plans and a 4th federally qualified high deductible, and I think that would be a wonderful mix for your staff. So, my time's up. So, thank you very much for your time, and I'll be around if anybody has any questions, so thank you very much.
Okay, Brian from Aetna?
Yes. Sure. We'll let you, that's a good contract change.
I don't have an extra one.
Hey, Ted, can I add one other thing? This guy asked a really good question that might be applicable to the board, but if you offer 4 plans and you go on the high deductible, every year you'd be allowed to change.
Right.
So if I move, and his question was, well, hey Bruce, if I move on the high deductible, could I next year move back to one of the other plans? And we allow that movement. You could move to any of the other 3 options. But once you elect it, you're locked into that for a year.
Yeah, that's why you have open enrollment.
There you
Well,
go.
that's where I was before. You could only move 1 step a year. You couldn't move from 4 to 1.
And we used to do that, and we're changing those provisions to allow movement into the options. That'll be another contract change.
Okay, so
Yeah,
that's good.
good question. So thank you guys. Yeah, that's a great question.
All right, thank you. I'm Brian Rose with Aetna, and my history in Wichita goes back through the old Preferred Health days, then Coventry, and then Aetna was purchased by CVS. So there's been a lot of things that have happened that over the years that I think have really brought forth some opportunities to help individuals make better decisions about healthcare. In days of old, you went in, you had a office visit, or you had something, and then you got a bill 30 days later. And I kind of envision that as, if you go into the grocery store and you fill a basket full of groceries, and you come in and then you get down there and they beep, 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 and they walk out and say, we'll send you your bill 30 days from now. We wouldn't want to shop like that. But one of the things that we're going to talk about is transparency with regard to, and I know we talked about this a year ago. Thank you for inviting me back. But I do want to kind of walk through. On the right-hand side of this is just a little PowerPoint that I worked up, because I was kind of looking to see, what did we talk about? What makes us different than, maybe some of the other carriers out there? So if we kind of go, and then, this front page really is one of the things we came up with. As you see, my ugly mug's down the bottom right-hand corner, but all of these individuals work actually out of the Kansas City market. So, different individuals have different jobs, but we truly believe that, it's Kansans that are here, that are taking care of you, that, when you have a problem, you're gonna be able to get a hold of me and work through stuff. The next page in there, we've still got a few more pictures as well, but when we join individuals on their personal health journey, okay, we're gonna make care simpler. I can't tell you how many times that I've got a call from one of my cousins or one of my aunts or uncles, and my mom's from a family of 16 kids, so I get a lot of calls about health insurance stuff. But they say, hey, where should we go for this, or what do we do in this instance? And and then you got to go back and kind of walk through and say, okay, what are you really trying to accomplish? I mean, just the time that you go in to talk to your doctor really isn't, and what you're going to see in some additional pages really isn't what is going to help us in the long run get to our personal health goals. The next page on that page 2, this color page, what we're going to do is come in. Aetna brings a wealth of support around you, whether it's telephonic, whether it's on your mobile device. If you have a smartphone, you can get to all of our tools there. You can also go online through a web enabled. So there's a number of ways that we can reach out to help impact you. What we figured out is not everybody wants a phone call, not everybody wants a text, not everybody wants to do it one way. But as you look at your employees, some of your millennials, they may want to do everything on their handheld. You can do that. Some people may just want to do the online version. But we're going to provide the tools and the resources in whatever way that you want them, because if we can help you to make better decisions, then you're going to be a lot more empowered to make even better decisions in the long run as you're trying to decide what you're going to do. The last, not a bullet, but in the high quality, cost effective care using local models, the delivery of healthcare is a local phenomenon. Your local doctor is going to be the one that's going to make the decision. Your pharmacist is the one that's going to help you decide where to go and what drugs might be best if there's a generic available and all that. But we're going to work through a number of local scenarios, and we'll get to that in a page coming down here. Okay, jump over to page 4. Here's, and this is so kind of elementary, but we had, Aetna in their infinite wisdom paid a fair amount of money for some focus groups and some studies, and what we found is the top bullet and the bottom bullet is employees want it simple, and then they want it personalized. So that's kind of how we open the viewfinder to say, okay, how do we make that happen? So the additional pages coming up, this next page, in the old version of healthcare, we focused an awful lot on just claims. And when you focus on claims, what is a claim? Well, it's something that happened back some other time. You can't change the claim. I mean, you could withdraw it. You could say, well, I didn't really have it. Well, you had the claim. All right. So when we're looking at a lot of these scenarios, we're really trying to shift our thought process from health risk to assisting individuals to reach their true potential. And as we look at this, a lot of times say, well, it's just my genetics. I'm just born with these genes. I can't help it. Well, the study shows that truly 70% of what happens to you on healthcare really is within your control. Whether it's, diet and exercise, whether it's care plan adherence, economic stability, the actual clinical care, what doctor you go to is really a small part of that. So we want to be able to come in and say, okay, how do we build a model that's gonna truly help people make better decisions, help doctors to make better decisions on your behalf as well. The next page, just a little bit talking about, I'm a kind of a car buff, so Care Engine. Really, all of your claims, if you go out there and you take a health risk assessment within our programs, all of that data gets compiled into one. I call it a big repository, but it's a big database in the sky that we keep very secure. But the care engine is looking at your medical, pharmacy, lab, plan, member reported, and it's then going through algorithms and saying, you know what, there's over 250 covered conditions and about 1,200 different care considerations where it says, you know what, wow, Brian hasn't filled his high blood pressure medication for 2 months. I wonder what that is. So it would send an alert out to the provider, hey, get with Brian to see what in the world's going on with, why is he not? Well, did he fill it early a whole bunch of times so he had too much sitting there? And that may be the answer. But at least it's going to give actionable data to be able to move forward on. Going into the next page, you have it's actually 2 pages down here, but the right experience for every member. I like that. Well, I just moved recently, and the boxes kind of gave me a little shock. But I'm kind of tired of looking at boxes. But this is our smart app. All right. So when you look at that, on your Find Care, you can see, hey, I want to know, is Dr. A in the network? Great. Well, I need a cardiologist. How do I know who's good, who's bad, who's whatever? Okay, well, within this, when you go into Find Care and you look up Dr. A, you can see if anybody's taken the time to go out to, put in comments about, hey, doctor was great, you can be able to see the comments, and then you can also see their rating, as how are they doing in that. Managed claims, a lot of times, when you get a claim, you don't know, what was this claim for? You don't realize that the doctor took this lab and they sent it over to some other lab and you said, well, I'm getting a bill from over here. Well, you'll be able to tell that by looking at here. See coverage and cost. This is the ultimate game changer. And I agree with Bruce 100% on the high deductible health plans. It helps you become a better consumer. And, Bruce talked about the discussion that he would have with his wife. I'll tell you the discussion that I did have with my wife. 3 years ago, I moved to a high deductible health plan, and she went to get my daughter's prescription filled the first time, and it was $13. It was $13. It wasn't the copay, but it was $13. She said, "What did you do?" And I said, "Remember I talked about the HSA? Everything goes toward deductible first, and all of that." And then came time for one of my son's prescription, and it, on the other hand, was $200. Well, guess what? There was a generic available, and so I got it shifted to a $6 prescription. Well, I'm under a normal copay scenario. I'm under no incentive. If I want to pay the additional amount of the I don't have it. But what this coverage and cost estimator allows is there's an assumption that everybody's contracts are pretty close to the same. They're not. Even within Aetna, I may pay Via Christi for an MRI of X. I may pay Wesley X minus 2%. I may pay a freestanding 50 cents on the dollar of what that is. And I can tell you that really is what's happening. So you have the opportunity, if you're going to be on and it's all your money, okay, and you're looking at this, don't you want to know before, back to my my grocery store analogy, don't you want to see the prices before you go? Well, we have the opportunity now, and this actually, what I like about this is it's not our 3-year average of costs. It's not our, what did we think that this was doing? Do we, do this huge database that has other people's claims in it too to get averages in the community? No, this actually acts as if when you look up and say, hey, I need an MRI of the upper body with no contrast. Okay, you plug that in, and it'll give you. I like to limit it to 5 on the phone because you get too much more, and you can toggle how many you want to see. 15, you can see a good. When you're on the computer, you can see a lot more than that. So I would suggest that. But you can see that one of them's $1,200. We got one that's $1,150. We've got one that's and it'll actually show you how much was deductible, how much is going to be co-insurance, and you'll know exactly what you're going to be spending before you go have that visit if you choose to look at that. Additionally, on the prescription drug side, is we can help you with the find a drug. And you can also look and see, pharmacy to pharmacy, is there a difference in what they've negotiated, and there are, and you'll be able to do that. So it's really giving you the opportunity to become a consumer, and that's what I think. Talk about that personalization. we're going to be able to do that, I think, a lot better than most people in the market, because I've actually seen it and watched over it. So you can see what the costs are beforehand. You can figure out on the pharmacy if you may need to move pharmacy and all that. And then you can also, on the Stay Healthy side, you can take, health assessments. You can, a number of things that you can look at on there. The thing that I would love to tell you is that everybody loves insurance companies, and what we say is, people are hanging on our every word. Well, what I will tell you in practice, when the phone rings and it shows Aetna, and maybe it's one of our disease managers trying to reach out to one of the diabetics to say, hey, we've noticed, you haven't done this, or you haven't had your eye exam or whatever. They see that Aetna and go, okay, hopefully they'll leave a message. Well, we can't leave a message, that's why we're calling, because that would be, potentially a PHI issue. So we've got to hope that they call us back. Well, as I mentioned, the PHS to Coventry to Aetna and now to CVS, one of the things that's going to be extremely beneficial going forward is now that CVS owns us and they're also our PBM, when you're going into, let's say, a CVS pharmacy, and maybe they've got, it's not going to happen quite as quickly in this area as it is like in Kansas City's where they already have their minute clinics, but that pharmacist is going to say, hey, Brian, do you know that Aetna was trying to reach out to you? We've got a care manager right around the corner here, so would you talk to him real quick? Because the studies do show that people like their pharmacist a lot more than they like their insurance company. I mean, the way that it is. So that's going to be one extreme benefit in being able to try to determine how do we move the needle truly in a meaningful way. The other thing is you're talking about looking at self-funding. Okay, with self-funding, and I understand that it doesn't make sense today, and a big chunk of why that doesn't make sense, as Bruce mentioned, credibility. We're going to take our average or our manuals, and then that's either going to help you or hurt you. If you're running below manual, it's going to hurt you, because that 60%, if we use 40%, I don't know what we did on this group specifically because it's a brand new group, but when you get into that self-funded and your claims are your claims, and every time you have a claim, whether it's every week or every other week or whatever, when we wire that money, if you've learned and through our fully insured program, if you've gone in and actually figured out, I could save $600 on this MRI if I go here versus here, and it's 2 more miles, or it's closer, whatever you may know, or wow, I didn't realize this was costing this much. Lab is a huge one. There's massive differences in the lab costs in that, whether you go to one of the local hospitals, a lot of times that's some of your highest cost versus getting into some of our other alternatives. But as you're looking at that self-funding, when your claims become your future premiums, and it's really 100% experience rated, you want people making the best decisions. So getting into a program that allows that, and let them practice on fully insured when it's our risk, and then you can make a better decision looking at the self-funding in the long run. The next page is just kind of what the screenshot looks like on the actual computer. You can see a number of things. I'll go ahead and work to this next page though. This is really talking about there's over 650 services where you can get real-time out-of-pocket. Know exactly what it's going to be. You can compare 10 providers at once, and again, like I said, don't get more than 5 if you're looking at it on your handheld. Then you can also see the patient ratings and reviews, which that is extremely important. The next page is just talking about cost-effective models of care, and this is really what I think is the other thing, other than the tools, what differentiates us from a lot of the other carriers doing business in this market. Okay, we've got the triangle. All right, you've got your bottom 2, your patient-centered medical homes, your paid-for-performance. In the old days where you had the fee-for-service, you go in and then whatever the doctor does, then they send us a claim, we pay, and you pay your portion, we pay our portion, all that. That's what's here on the bottom. The higher you go up this continuum into the smaller portion, you have accountable care, ACO attribution. I don't like those. This is my personal bias, but but, and we do have them, and other people have them in this market as well. But high-performing networks, that's really where you start getting into being able to move the needle. And ACO products, and then you have joint ventures. So I'm going to focus more on, well, I'll talk about the attribution model. The attribution model basically is you don't select a primary care physician, and you maybe have seen Dr. A one time 3 years ago. Well, I would be attributed to them, and they're supposed to be managing my care, but I don't know that because it's behind the scenes. And you know, that doctor, if you come to him, they're going to say, hey, we really ought to get some of these other tests done and all that. But because you're just attributed to them, you're not actually assigned to them, they don't really have the opportunity to. And what we see nationally, you know, and Aetna has hundreds of thousands of people on these different models, and we see that it saves less than 2%. You might get 1.5%, 1.75% of savings in claim cost versus an attribution model versus just your normal fee-for-service. Okay, so then you get into high-performing networks. And we didn't quote this, I don't know if you had it on the spreadsheet on our Wesley Preferred. Okay, Wesley Preferred is a scenario that in the Wichita, you know, all of the doctors up here are in, but if you go into Wichita, you would not be able to go to Via Christi, you would not be able to go to Kansas Spine, Kansas Heart, or Kansas Medical Center. All right, because Wesley came in and said, we're willing to take significantly less, okay, if you tell everybody that they need to come to us. Okay, so they're basically giving additional discount for additional volume. Okay, so in those scenarios, your high performance networks are extremely valuable. You'll see it's about a 9%. I mean, I can't remember exactly what because we looked at that early on. But last year you guys didn't really go that direction. So, and it was significant savings, and we could do that as well. The ACO product. Okay, now we call them ACOPs, but ACO product. That's really where you get a lot of your bang for your buck. Okay, back there when we had the sheet that had the engine and it talked about, you know, we're communicating with the providers, we're communicating with the member, we're communicating, you know, we have all of those coming out. So the higher you move up in this metric, the more reward a provider would get. So in an ACOP, your primary care physician, because everybody's going to select a primary care physician at that point, and they're going to help route you to where you really ought to go to cost-effective and high-quality care. All right, so within that, the better they do at keeping me healthy, the more money they can make, because we'll set targets, and then if they perform underneath the target, that's going to benefit the plan because you're going to have less claims, but it's also going to benefit the employee because they're going to have less out of pocket that they're going to have to pay as well. So within this, the data sharing really becomes actionable data. Okay, I can give data all day long if you don't look at it, you don't do anything with it. You just got a bunch of data, and it's like great, and then you set it over on your shelf and you never look at it. Well, within the ACOs, we're going to be giving that doctor, and we have some of them, depending upon your patient, but we can communicate with them daily if they want us to. But we're going to be sending data basically saying, hey, you know what, you've got 27 diabetics on your panel that haven't been in to have an eye test. They haven't, had the other, the foot check and all that. Well, and then they would then turn around and try to reach out to say, hey, Brian, you want to come in and get these things done. Okay, because what we know is the more preventive we can get, then we're, staving off a higher cost. And I like to say a lot of times the best discount is something that didn't happen. So it's 100% discount because we got in and we didn't have somebody that actually went blind as a result of not taking their insulin or not doing whatever they needed to do. That's your best scenario on that. So this page really, this page and the transparency tool page are the two things that significantly differentiate us from all the other players that are here in town. I know we didn't quote the dental, but we could quote the dental, and why I brought the dental out. And on the right-hand side of the left-hand side of your package, you don't need to look at them now, but there's just a couple pieces of our dental medical integration and our vision medical integration. Okay, and you kind of think, dental medical integration, why is that important? Okay, we did a study, it's a 2-year-old study now, where we looked at and we said, does someone's dental health have any impact on their medical health? Okay? And through the study, what we found was, I know this is going to sound extremely elementary, but, the mouth is kind of the highway to the body. The quickest way to get something in the body is swallow it. I mean, it's there, obviously you can inject it, but that hurts and I don't like needles. But with regard to the dental medical integration, there are 3 types of disease states that we focus on: cardiovascular, okay, diabetes, and preterm low birth weight pregnancies. Okay, so if you have our dental and you have our medical, okay, through the medical, if we identify a claim, hey, Brian's wife is pregnant, that would be extremely funny because she would not want to be pregnant at this age. But, sorry, I found that so humorous thing to say that, my wife's saying, she's pregnant. Well, then we would come in and say, hey, we realize you've already had your cleanings for the year. We want to bring you in. We're going to give you a free cleaning on the dental program, so they have additional services. You can get additional cleanings, additional periodontal work as well if you're pregnant, if you have cardiovascular disease, or if you're diabetic. So when you look at it, and we can have all kinds of, we talk about case management and talk about all those. If we can keep one preemie from occurring, and I know a significant amount, my oldest was a 29-weeker and then I adopted a 26-weeker, so I've been all the way through that. But if, periodontal disease, if we can, give the extra cleaning and another scaling, and then not have a $500,000 baby that's out there, that's a huge benefit. When we individuals that had longer period periodontal had 12% lower medical costs. Individuals that had dental treatment consistently over 2 years, where because we're going to be communicating through this dental medical integration, they had a 27% lower risk scores. And by risk scores is when we look at everything that's going on with you, we try to predict, okay, what's Brian going to cost a year from now? Well, individuals that have worked through these programs have had a 27% lower medical risk. So it's not saying that you might not have a heart attack, or there still may be those things that happen, but overall on this entire study, they had that. Also, the participants within this program had 22% reduction in hospital admissions, 5% lower overall medical costs. So you see that there's a significant benefit to putting those 2 things together and then having us work together, give those extra services to try to move forward. The other thing on your vision, a lot of this is going back to diabetics, because what I didn't realize was diabetes is in the 20 to 74 age category, is the leading new scenario of blindness. Anybody that becomes blind in that 27, it's probably because of diabetes. That's the highest one out there. So we're taking our vision benefits, which and we do have just a normal vision exam. You can go on any one of our plans. It's paid at 100%. But when you buy our vision products as well, where you get the additional stuff, we're gonna try to keep that in there. And I think that's another reason why we also have 100% coverage on all of our plans, because we want you to go in there. We don't want to have that adverse effect. The plan designs, mentioned before that Sally did a really nice job. We do not have a coinsurance maximum on ours, so what I try to do is I try to come up with a number in between the MOOP and the coinsurance plus the deductible max. So, I know you've got the plan designs and all that. I don't want to really go through a whole lot of that, but we do have a number of options that are out there. I do want to leave with you with the transparency tools, getting people to use those, and if you go in and save a significant amount of money, we looked at, my daughter needed an MRI, and the place that our doctor said, hey, you ought to go here, okay, we have a Via Christi doctor, and he wanted us to go to one of the Via Christi owned facilities, which we normally do, but when I went on my little handheld, and I said, whoa, hold on a second, that's $1,300. I can go over to this freestanding one, it's tall grass, that was out on the east side of town. I had to drive across town, but it was only $600, $628. So that's a significant savings there that because, I mentioned earlier I'm on a high deductible health plan, I didn't have to write the check up front. And the cool thing is on the high deductible health plans, and I know you guys don't have one of those today, but I said I've been on it for 3 years. 2 years ago, my wife had a big emergency room scenario and has some issues with her gallbladder. Well, guess what? I hit my deductible, I hit my out-of-pocket max, but I had the money sitting there, and I didn't give it a second thought. I just used my flexible spending card and said, here, pay for it. We had that in there. Now, last year she maxed it out. Well, I had the money sitting there, and I've already got almost $1,800 in there for this year. So, you do have the opportunity, but you have to be disciplined enough to put the money in. So that's the one piece that I do think that if you're going to be a good consumer, use all the tools that are available. So questions about Aetna, about our proposal, I can talk plan design as well. I didn't want to go usually because I think your spreadsheet has all that on it.
We don't have that yet, though. No.
Okay.
She's getting ready to get
Okay.
Back up here on page 12 under accountable care organization, you was talking about primary physician,
Yep.
ACO, and you want to go somewhere else, do you have to go back and get the primaries?
Permission, yes. Yeah, that's on not on the accountable care attribution model.
Okay.
That, you don't have to do it on that. But
Okay.
on our ACOP, and that's not something we quoted, but that's a brand new product that we're rolling out with Via Christi, that you would select a primary care physician and they're going to route all your care. So if you had a situation in the middle of the night, you could call them and say, hey, Dr. H, need a little help, where should I go? And they'd say, well, go to the emergency room or go wherever. But yes.
And then, under the stay healthy deal under your apps and
Yep.
things, does your company have programs to where if we do so many calisthenics and that kind of stuff, or go do this and that, we get a discount on that or anything?
I don't have it per se in that. We do have a number of discounts that being an Aetna member, you can go out and get. We don't have, on a group, in this size segment, we don't have quite as many bells and whistles as I do. If you get over, 100 on the plan, then I've got a few more things where we can actually give you gift cards if you do certain things and all of that, but that's not included in this program. But you do qualify for any of the discounts that just come as being an Aetna member. And we have, the other day, something came across that I could get a free ADT system on. That had nothing to do with it. I guess peace of mind if I was worried that I was going to get robbed and that was causing me stress and I had bad out. I guess it does technically tie back to there, but it's a stone's throw out there.
Two I had.
Anything done?
Brian, I have a quick
Thank you,
question.
Brian.
Yep.
Where does Aetna get their provider ratings from?
Couple of places. One place is we have an extensive, we tie into the Medicare base where they look at. We have star ratings and different things that we have, so we get them from there. We also, though, get them from interactions with additional providers. We look at claims data all the time and trying to determine through that whole ACOP, where we're looking at what are the outcomes of these providers. So if we go and talk to our primary care physicians that are on that and say, hey, you know what, these ear, nose, and throat specialists, that are in these 3 locations have the best outcomes, they're going to flow through in our ratings as well.
Thank you. And Sally, I guess we're back to you.
Yes, thank you. Okay, so what I've got first off that we're gonna go through is a spreadsheet that explains benefits that are somewhat similar to what we have in place today, so you can see the closest, if you will, because again, everything is fairly different in terms, some might have the same copays one place or another, and tried to find the best pinpoint or happy median, if you will. And again, it's what Brian had mentioned, these plans do not require primary care authorization to go to specialists, but if it gets to a point whether that makes sense or if it makes sense to limit the network in some sense for later on discussions of additional savings, that's something that additionally Aetna has as well. So what I did, what's in front of you, is the comparison basically on what we have in place today and some other plans that are, again, somewhat similar. The option one that we have is $1,000 deductible. So again, that's not the same as our $500 deductible. It's different. But as we've seen from the benchmarking data, there's not that many groups that still have that $500 deductible. And I'll say I may have met my deductible one time, and it may have been when it was still below $500. I have 2 chronic conditions and I'm on a high deductible health plan. I've come nowhere near meeting those, but every year, because I've built up my health savings account, it's like Brian said, I don't sweat it when that bill comes due. I'm not worried, how am I gonna pay that, because I've budgeted and because I'm not paying taxes on that amount, paying for it pre-tax. It rolls over every year, and then if I decide next year, I don't know what I was thinking, that's not right for me, I can switch to another plan. I still have that money to use. It's not a use it or lose it. As long as I have one of those qualified plans in place, then I can continue to accumulate money towards that. We typically, or I'll say I typically work with Mid-America Credit Union to put the health savings accounts in place because there is no fee. And it's easy to administer that way. They get a card to use, so if I get a prescription, I use that to go. And Mid-America Credit Unions, like other credit unions, there's not a requirement to go to one credit union. They all sort of work kind of like the same, basically. And so Aetna has, this is in the medical portion. So when it gets into dental, of course, they've got additional options if that's ever something that wants to be considered as well. I know, to Brian's point, the Mayo clinics have put out reports that show that the plaque in your teeth relate to the plaque in your heart. You would think, really? Duh, I guess that makes sense, but it took me a minute to get there, but it is true, it's all interrelated. But so what we've got for that option one, that's a $1,000 deductible. The coinsurance maximum is actually the same as what you have at Blue Cross at $2,500 because the maximum out of pocket, which is that deductible and coinsurance added together, is $3,500. Another difference between the deductible and Blue Cross is that any office visit co-pays and drug co-pays, like Blue Cross, accumulate towards that maximum out of pocket. But once you've met that $3,500 on Aetna's, you're done for the year. Blue Cross's is $5,000, and that's a happy medium in a lot of cases. From that benchmarking data, you'll see that even though plans had higher deductibles overall, some of their maximum out-of-pockets were a little bit lower. The office visit co-pays lower on the primary care at $25, but a little higher on the specialist. We don't want to go to an ear, nose, and throat doctor if we just have a common cold. And so sometimes it makes sense to do that in case we don't know. There's higher out-of-pocket expenses for emergency rooms, and oftentimes that makes sense. When we're doing employee meetings and explaining benefits, we're saying, hey, get with your supervisor and say, I'm not feeling good, I want to make sure I can get to the doctor beforehand or talk to my doctor so that we don't have an exposure, not only affecting the employee but also affecting Marion County on the claims costs. So we try to do that in the communication piece on better usage of claims costs in general. And then you'll also see that the drug co-pays are different. Again, some are higher, some are lower. As Bruce had mentioned, there was no one reported to have specialty medications yet. Again, that could have happened yesterday and we wouldn't know. But with specialty medications, over 90% of those specialty medications that you hear commercials about have a co-pay assistance program. And so most oftentimes they're able to get a coupon that they pay either a $0 co-pay or a $5 co-pay. And so it's actually easier or lower costing, I should say, to go that route.
Something I also do, because I'm on a qualified high deductible health plan, is I use Good RX. You may have heard about that, but it shows me like if there's 2 pharmacies local, which one's gonna have the better cost for me. So I use that and get it filled that way as well. And so you'll see that there's premium difference down there at the bottom. That one is higher, but again, that has pros and cons. The maximum out of pocket is lower. This is the richest plan in this set of offerings. Of course, there's different ones there, but these were closest in that happy medium compared to what we have today. The option 2 difference is this is a $2,000 deductible and $2,000 max coinsurance, but the maximum I pay out of pocket is $4,000. So that's still lower than overall what I have today. Again, even though I have those 2 chronic conditions, I've never met my deductible, and I kind of think it stinks in that sense. Darn those insurance companies, but that's a part of, you know, what I work with. But I understand that that's really not what insurance is there for. It's there for me not to go bankrupt, and I use that health savings account appropriately, and to be able to use those transparency tools to find out what's the better place to go. It's a huge help because we've used that ourselves. So that has some pros and cons: higher deductible but lower maximum out of pocket. Co-pays are a little bit different on that, and the co-insurance is that 20%. The option 3 is for those folks that want to be able to get their maintenance medications, have the office visit co-pays, but don't expect anything really too much in the future as far as claims costs. It has a higher deductible, but the maximum out of pocket is the same as what you have today, that $5,000. So if I have a horrible year, the worst case scenario is my out of pocket is the same as what it is today. And then the last plan on there is the high deductible health plan. It's qualified, meaning it meets the IRS guidelines to coexist with a health savings account. This one has a $5,000 deductible. Mine actually is a $7,000 deductible. But the point is I get the discounts from the insurance company, and slowly over time as I build up my health savings account, I use that. I have a couple of reference letters from a couple of other counties, and they actually have qualified high deductible health plans. One I know is well over 50% participation on that plan, because the point is that you can never make everybody happy, right? You probably tried and you always have a few complaints. I feel like that with my kids, even though I only have 2 kids, but at any rate, it still offers those different plans. So if there are people that feel that comfort of the copay, I know if I go to the doctor, I'm only gonna have a copay, so I'm okay. I don't wanna worry about having that extra account. But to Bruce's point too, is that builds up over time and that savings. And the point is to have that health savings account, if that's a plan that is elected on that first day. Because if it's open on that first day, even if I have a 0 balance, I can go back and fund that when I can and still continue to pay for any claims that I need to that have happened. So I still want to open it on May 1st, even though I may not be able to fund it maximum day 1. I certainly couldn't, but many of our groups that we work with also help contribute towards that. And a lot of times it's not a huge amount at first, but again, it builds up over time. And so some people may balk at that out-of-pocket expense because it's staring at them in the face and something happens and boy, there I am. What a lot of our groups have done, in fact, one for a January 1st effective date, they put in the first $100 for the employees that did that, and then they would match them dollar for dollar. You can't do that 4%. That's the way IRS wrote that legislation. But by dollar amount, you can match them up to that maximum that you can put in there each calendar year. And so if I put in the calendar year maximum for 2019, if I want to, I can put in the additional amount January 1st, because it's a new calendar year, even though this plan starts over every May 1st. And if I'm between 55 and 65, I can put in the additional catch of $1,000 if I want to as well. I'm saying that stops at 65 because when you become Medicare eligible, then that changes some of the regulations on being able to contribute if you also have Medicare. Most folks take Medicare when you're 65 because you've earned it throughout the years to not have to pay in at that point. But we get into those details at open enrollment meetings. I will say that even though it's a different plan, it's a very simple plan because you have a deductible, and then once that's reached, if it's reached, you might have co-pays on the drug plan. And so I know what I'm getting there is the idea of that discount for the insurance carrier. So I can use those transparency tools to find the best cost for myself. I know what my maintenance medications are each month, so I have that budgeted in there. Any questions on those plans?
The health savings accounts are all done through regular payroll reduction.
Yes, yep, and so ideally, it's like a flexible spending account in the sense that whatever I designate to come out of my paycheck comes out before taxes, and then it moves to that account that I can use for my health savings accounts. The flexible spending account and health savings account can be used together. Usually they're not though, unless you have major dental work that same year, because the dental and vision is all you could use a flexible spending account for if you also had the health savings account. So the first three options typically used for the flexible spending account.
You were saying there's a catch-up provision,
Yes.
and that's where you'd have to basically write a check to fund it.
The catch-up provision is if I'm 55 years old, instead of having that normal limit on putting in my health savings account, I can put in another $1,000 if I want to. But it doesn't mean I write a check for any more or anything like that. It just means I can sock away more for later if I want to. Kind of like 401ks in that sense. Again, with Aetna, if it gets to a point where savings looks like another way to try to whittle down in the future with different networks or requiring primary care physicians. I can talk about the Wichita network, for example. The hospitals have had different ratings throughout the years. That changes. I've had years past, some folks say different things about different hospitals. I'll say I have never once had a good time in a hospital, but the ratings are what I go to. And so Aetna has different contracts with both networks, and the purpose is to get additional savings for that restriction. And just to know those ahead of time. And does anyone have any questions on the Aetna plan designs? I will say also that as a long-term goal, potentially, of looking at health insurance, there's a couple of differences on how any carrier, any underwriter rates. And so something to keep in mind, perhaps, is if that is a goal that we have in the future to be self-funded, when we go outside of carriers and look at self-funded plans, we do what's called a different rating on contracts. If I can, I'll refer you back to this page that has that big long list of information on that page. And the reason why I want to refer you back to this page is because out in the self-insurance world, if we're coming away from fully insured and onto self-insurance,
That was in that first group of stuff.
yes. I should have said, hold on to that. Yeah. There we go, okay. So you'll see at the top, when we move away from a full insured to self-insured, without a carrier. Typically, we do what's called a 12-12 contract the first year. And then the second year, we want to cover expenses that are still in that first plan year, but we haven't received yet. So it switches from a 12-12 contract, because the 12-12 means that any claims that have experienced in that 12 months get paid if they are received in that 12 months. So when there's run-out claims of claims that you haven't received yet, but it happened in those 12 months, then usually it switches to paid contracts. They're called paid contracts, and they're also called 30-12s or 24-12s or something to that effect, because anything that is received 18 months before the next plan year gets paid in that current plan year. And so that's a difference with Aetna and Blue Cross, in the sense that Aetna switches their 12-12, the first year self-insured, to that run-in protection. And the purpose of that is the first year, because the contract costs significantly less. That's the time you're able to build up your reserve and gear up for when you're paying for run-out claims too. And so a little bit difference is that, again, any carrier or underwriter will rate differently if you're self-insured or fully insured. And sometimes within carriers or outside, they'll use different credibility and all that. Blue Cross, on the other hand, is consistent in their rating for fully insured. And so sometimes it makes sense to do fully insured, and we've learned this hasn't been a stellar year for us claims-wise. But when we compare the proposals, if you will, from fully insured to self-insured, it's more expensive on the self-insured side because there is run-in protection, but you already have that from your fully insured contract. Did that make sense?
I don't think it probably did to them, but really, you're not recommending any kind of, that we're gonna be looking at self-insured this year at all.
I'm not recommending self-insurance this year.
So what she's just said, all of that, it just pertains to if we were gonna switch to self-insured. She's, yeah.
If we do look at sometime doing self-insured in the future, there's an initial 1-year savings if it's Aetna, because you're not paying for run-out claims, and that year you build up the claim reserves to pay for future when you are self-insured.
One thing on your sheet that's kind of interesting, this sheet that you have with Aetna on it. The option 1 on Aetna is really kind of similar to what our option 2 is today, right? Because of the deductible and those things.
The deductible is the same, the co-insurance maximum is the same. I'm sorry, the deductible is the same as option 2, and the co-insurance is the same. The maximum out of pocket is $1,500 less than what you're paying out. Yes.
Right, but if you look, so our current option 2 level would be that most rich benefit that somebody could get if we switched to these plans.
That's correct.
So right now for our option 2 on Blue Cross, we're paying $661. Our renewal is $705. And then the option 1, which is similar to that option 2, for Aetna is $706. Is that right, Sally?
That's right.
Okay.
And so it's not an even comparison. And when you do the comparisons of the contract counts, you'll see that there's no way to know how we know people are going to enroll. What I usually try to tell people to do is, what I do every year at open enrollment is I look at my claims to see, did I come close to my deductible? If I did it make sense financially to have that deductible? Or if I didn't come close to any, and that was a normal year, and I expect next year to be a normal year, is it important to me to pay a higher premium when I'm not gonna use my deductible? Or maybe should I use that money to put in a health savings account for that additional savings? I can say we put in about 10% into that option 4, and what we see with the groups that we have that are high deductible health plans, and maybe it typically comes from years being in the high deductible health plans to know and appreciate one way or the other, to have that gravity effect towards those plans. Coffee County, for example, has well over 50% in their high deductible health plan. They also contribute some towards that health savings account. So you also want to look at not only the premium wise, but what does that mean? Are we going to put in any money? Whether it's a small seed amount, match maybe $20 a paycheck, something like that, or none at all. What makes sense to us overall from a budgeting standpoint? And so we don't know how people are going to enroll. It may be different. So that's a definite consideration. I can say that, yeah, so we normally see 10 to 20%, but it really varies on how many do participate in that high deductible health plan. First off the bat, it may be a handful. It may be 0, but we tend to see more than that.
And is there a limit on how many would have to enroll in each plan?
I don't believe so.
Okay.
And I don't believe that's so with Blue Cross either. Okay. Those are just options that are available there.
Thank you.
I guess I have a question, I don't know, it's not a question to anybody, because nobody probably knows the answer. I'm just looking back, we're saying that we're having higher expense years than we have had here the last 3 or 4. We've also, in the last 7 years or so, we've also hired more employees. We got more employees. Does that have anything to do with, you think, having more employees, having more, raising our, I mean, we've doubled the sheriff's department, we've doubled the jailers and things, and so I'm just asking if that has, you think that maybe that's causing our...
Well, it has an effect because you're paying premiums for more employees. So your overall benefit cost does go up. The claims themselves, I mean, I don't...
Yeah.
I mean, Randy, you could probably, we could probably pull it and look at it on a cost per contract basis to come up with a, with a true comparison. I think what you would find is,
Depends on age of people.
yeah, I was gonna say, I'm not too sure you could draw many conclusions from that.
Especially if you're bringing in, it's compared the premium to the claims, so it should be relative.
Well, we would all like to see it just take the nosedive the other way back, because we have 7 years ago, we did have a year or two that went down and stayed down and then come back up again.
Has your sheriff's department, is that average age, do you think, increased?
Maybe the sheriff.
It's probably going the other way, hasn't it?
I think it's
Probably
probably
younger
younger.
guys.
I think it's younger, probably, yeah. I think it probably has. And stuff, but Rob's gonna shoot me here.
I know, you better be careful.
But then we have other departments that the employees are, been here for a long, long time.
Yeah. I'm just wondering, keep talking about this goal here, I'd like to see it go down, but I don't know how. I mean, we can't, it's staying here the last 3 or 4 years, just staying up here.
Yeah, and a hard part to doing that, there's been different ways to conquer that. Some put in plans that have more of a point of service or HMO program. And that has pros and cons like any, because sometimes employees like those, sometimes they don't. But that basically has more of a management type policy that the doctor, the primary care doctor, takes ownership for. They get stipends every month, but they take more of a role on, I need to make sure that you're getting the best managed care. So you see me first and you don't go directly to a cardiologist if you're just stressing out about something minor, we need to make sure it's the right way. And so there's different approaches to conquering that. With the point of service plans that most policies have that don't require referrals, every year providers are looking for ways to increase their revenue. They're businessmen just like anyone else, businesswomen, and they want to see 5+% revenue increase every year. Well, the way they can do that is to put more claims on the claims that they send to the insurance providers, along with getting increases every year. And so that's why a lot of those managed programs have been popular sometimes in the past. Another way that we see that is that transparency tool, which has been somewhat elusive by carriers in the past, and then just recently, Aetna's been probably promoting that the longest. I had Aetna for a while, Blue Cross now through Illinois, but Aetna, there's Ask Ann, I believe it is, on there. That's the gal that's able to help folks with the transparency model, and that saved me hundreds of dollars by using that. While thinking about that, I have a couple things more that I want to go through in there if you're open for it. So you've got that Aetna page that shows the comparisons, and there's the plan design. So if you want to dig in more details, there's those packets in there as well. Okay, so this I still need to hand your way. And this is just on Gallagher, something that is just about what my company does. I'm trying to think of it. Are you from Colby? Is that right?
Hopefully.
Oakley, that's
Yep.
Hutchinson, Hayes,
Colby.
Lowell.
I grew up in Colby.
You did? Okay.
My husband grew up in Oakley.
That's funny.
Randy Decker.
Something that I wanted to give to you so you can review, and it's a few more, it's more than a few words, so we don't need to go through it all right now. But I do want to say that this is what I do, this is what I do for you, is basically listed out there. And this would be if we stay with Blue Cross. And I can say that one of the things that we do that's included in here but not listed is we could, if it makes sense for Tina and Ashley to take over the flexible spending account, that's part of the administration of it. So they get cards, we administer that out of our office and put the plan document in place for that. And if that makes sense, if you're happy with tasks, no problems there, we can work with that as well. Another thing is that with if you decide to go with Aetna, we can manage the COBRA administration, so it's all centralized. If Tina says, hey, this person's with us now, or this person is not, we do the COBRA administration, whether it's giving out the general notice or providing them with the documents that we cover you in that sense. For the financial modeling, that's listed in that, but to give you an idea, if we say, okay, we've decided what our budget is for the year and this is where we think contracts may or may not fall, then we at Gallagher have a tick tally, if you will, on the budget. So if we say this is what our new budget is and we anticipate contracts to enroll this way, we can kind of find that happy median on what the new employee contributions will be upcoming to help with that. And if there's health savings account information, we can include that as well. Another thing that we have here, I just did a screenshot on websites that we provide our clients. It shows you their benefits as a whole. So it can also include the retirement programs for municipalities, as well as if they want to dig in further and see their medical, we log in SBCs. This one shows Blue Cross as an example that we've done. Also, how to get to those transparency tools. if that's something that's available with carriers. Who do they call at the insurance company? Or do I call Ashley for everything? Just kidding. I remember one of the commissioners, forgive me, I can't remember which one, asked, what do you do? How many municipalities do you work with? Specifically on the counties, I put this in here. This is somewhat of a proprietary document, but shows that we have 176 counties that we work with in our area. I put in 2 reference letters, so you can call them and say, what's up with this lady? And then just a more formal model that talks about who on our team helps with everything here. So we've given a lot of documents and we've talked about a lot of things today. What questions do you have, or is there information that you'd like us to send to you?
So are you actually administering plans then for counties?
We do the consulting, and if your question is in regard to like the COBRA or FSA, we do administer that, but for the others, we facilitate the carrier's involvement, putting all that together. The benefit guides, I don't know if I showed last time or not, but those are presentations that we give to employees at open enrollment at any time throughout the year, and also included in the website. So we typically handle those. We would, of course, involve carriers too. It makes most sense, especially for the medical. But it lists all the information out and who to get in touch with, whether it's us that can manage that or the carrier sometimes might be the best fit. With 4, now 5 generations in the workforce, as we've learned, a lot of folks like to just get on their handheld device. Other people like to have things in their hands, kind of both. I like to print it out and look. So all that is provided so that it's more of a comprehensive communications tool.
Anybody else have any questions? Sally?
I know that there'll be discussions coming up soon on what direction you might want to consider heading. Let any of us know. Of course, if there's questions, we'd like to discuss anything else at any time.
We're gonna have to make a decision in the next few weeks. Which route we're going.
So if any questions come up, can we call you?
Absolutely. Again, I'm Sally from Gallagher. My card is on the inside, and my coworker's in there as well, Rachel, that can answer anything. Can't see her, but she's there.
Well, we appreciate the knowledge that you bring
Thank you.
along with both you and gentlemen. Thank you for
Thank
being
you.
with us, taking that much time.
Our pleasure.
So we are tentatively scheduled to hold open enrollment meetings on April 5th, which is, so the next step, Sally she's got it in your folder, but I also had one on the table for you. So we've got a discussion scheduled for Monday, the 25th.
We need to know by the end of the month or prior.
Yeah, and so that's actually, you could take additional time on payday if you need to, just to kind of figure out what direction you want to go and so that we would be ready.
All right. This is our directions.
And if you do have, I mean, you can look through everything, whatever questions you have. Like Sally said, you can contact her if you have other questions about budget or anything like that. You know, I'm happy to visit with you on anything. So.
Do you have something, Randy?
No.
Okay. Well, if there isn't anything else, I'll make a motion to adjourn.
Second.
Move second, all in favor?
Aye.
Aye.